Hello, everyone. Welcome to our first DOCSF 365 Fireside Chat. By way of introductions, in case someone just joined us, I'm Dr. Stefano Bini, and I'm the founder of DOCSF, and I'll be the lead and the host for this conversation. I'm joined by Dr. Tad Vail, chairman of the Department of Orthopedic Surgery, my chairman, very proud of it, and Dr. Joe Bosco, the current president of the American Academy of Orthopedic Surgery. He's joining us from New York. And Dr. Danny Guy, the incoming president of the American Academy of Orthopedic Surgery, who's joining us from Georgia. Welcome to DOCSF 365, gentlemen.
Thank you.
Thank you, Steph.
Thank you.
I can speak, I'm sure, for both Tad and I when I say that we're delighted to have both Joe and Danny, both you guys joining us today from the Academy to discuss digital orthopedics. We're excited about the partnership we have developed with the Academy this past year. I think it's been a total win-win and look forward to collaborating in 2021.
Great. You guys have done a great job and congratulations on your success.
Thank you. As for the format, we'd like this to be a conversation, so feel free to build on each other's comments or anything else that comes to mind. But let's get right into it. And what I'd like to do is, we just heard a terrific presentation from Tad about what he called the musculoskeletal moonshot. So I'm going to quote him. He said, "We need to put maximum energy, effort, and investment in that exact part of the Venn diagram where the overlapping circles of compelling need, innovation, and unique application intersect." So I was wondering, besides with the Tad, you're an English major, because that was perfectly written at some point.
Hardly, but thank you.
Very well done. If maybe you can start with Joe, you provide us with thoughts on Tad's call to action around digital orthopedics and musculoskeletal care.
Well, I think, Tad is exactly right. First thing when I saw that Venn diagram, I wish I'd paid more attention in sixth grade math. But, I settled down and understood a little bit better. But frankly, right, we have this great opportunity up there, digital, our digital transformation. What does that mean for orthopedics and what we do, right? So we have to have the opportunity and we have to have the means. And I think we absolutely do. There's a way we could use it to help our patients and help ourselves give better care. And, we are working on that right now, but certainly in terms of enhanced communication between physicians, physician to physician, physician to patient, I think is where the sweet spot is with this.
Danny, what do you think of this opportunity?
Well, I'd echo what Joe says. It's a great opportunity for us, but we're all still learning, and things are changing so rapidly that what is applicable technology right now seems to be old hat in a year. And so we're venturing into telehealth, for instance, this year for the very first time, and we're forced there because of COVID. But it's been a useful tool for everybody, but we're still learning how to apply it in the best possible way.
Tad, is that the vision you were thinking about when you made that call to action for us?
Yeah, I think these guys are nailing it. The issue for me is that we can be proud of where we are. There's a lot of digital innovation that we can point to, but we don't have to be satisfied. I still think at this stage, despite the advancements that we have in digital technology and the great new tools, to some extent, we're disconnected still. As Joe was saying, disconnected from each other, the information that we can share about patients as orthopedic surgeons. Patients don't have access necessarily, and then all the information about patients that's out there isn't necessarily available at the point of care. So that's really what I'm thinking when I consider what are the opportunities, and it sounds like we're on the same page.
Yeah, no, I echo your comments. It reminds me a little bit about the early days of online banking, which kind of dates me a little bit, but it was a miserable experience. And yet today, online banking, geez, they've closed 2/3 of the bank's tellers because the interface is so much more useful. The information you needed was there. And so I kind of think that our current experience of telehealth and all the virtual platforms is really going to only improve from here. So our ability to interface with it and to stay engaged in the design of that platform as orthopedic surgeons, as musculoskeletal practitioners will really help create the communication tools that we kind of need.
Yeah, no doubt. Joe, Danny, I was wondering, what are you hearing as you talk to members? What are the stressors that people are feeling now that you think might potentially have digital solutions? Is what's in your ears and on your mind?
Well, Tad, it's interesting. I mean, there's a lot, and again, I think you around communication with patients and around communication with other physicians, and the way I look at it is, if I'm like a week late paying my credit card bill, everyone in the country knows about it, right? All the credit agencies. But if I see a patient from San Francisco in my office, I have no access to their medical record. And he asked why. Well, there's HIPAA regulations, but patients, are harmed by this, and physicians are harmed. And there's higher standard of what we're supposed to know and how we're supposed to communicate now. And I think that really the proper use and easing some of the rules around HIPAA and interoperability of these systems is really going to transform medicine. I mean, to me, we should have our social security number or whatever number we have, and any doctor should be able to put that number in and have access to our entire medical record. Anything less than that, I think we're doing our patients and a profession a disservice.
Yeah, just to switch a little bit from that, but Joe's exactly right on those things. I just give one example, and it's become more prevalent since COVID, and that is prior authorization. The amount of peer-to-peer calls that I personally make and that I hear from other colleagues has just gone up and up and up. And this is basically a manual system. There's no digitizing any of that prior authorization or peer-to-peer where we could make it more convenient for our fellows. And the question is this to improve care for patients, or is it to deny care for patients? And that's a real stressor for most people out there. And there's been some legislative interest in this in Washington, but it's right now it's probably a bridge too far because of the way insurance works. Because some insurance is at the state level and some is federal. And whereas Medicare Advantage, you might have an opportunity at the federal level, it does nothing for each individual state. So we do need some help on prior authorization, and that's just one other pain point out there.
Great point.
Of all the things we've been doing at UCSF, the next one I want to tackle is prior authorization, where in California, we do have some health systems that actually have digitized the process to the point where some companies are starting to offer the ability to streamline that process digitally. And actually, there's some interesting things that happen. I was talking earlier to Tom Barber in New York that he's doing too. It's even simple technology, but how to feed information to the insurer so it makes it easier for them to process it. So that is a really good opportunity for us to, as orthopedics, to converse with insurers and use technology to see if we can find solutions. Because I couldn't agree with you more. It is so frustrating, and even having denials the day of surgery or 2 days before surgery, things like that is terrible.
Right. We've had discussion at the academy level with insurers and payers, and they say, well, we really want to. The reason why we need prior authorization is to make sure the indications are correct. But those of us that have been around the block a few times understand that, well, maybe they're using it to delay care, because all obstacles, that's how insurance companies make their money, right? They collect money and they pay it out slowly. That's why people like insurance companies. But we can certainly call their bluff and saying, okay, let's just use a simple digital platform. We could check the boxes and send in things and upload x-rays if you want, rather than right now mailing or emailing x-rays to someone so someone can look at them and decide whether a person needs a laminectomy or knee replacement. I mean, to me, that's A, expensive for them, and B, not efficient. But I suspect a little bit of inefficiency is what they want, frankly.
So since you're on, Joe, I had a question lined up for you. How is the Academy working on behalf of its members to ensure adequate payment models for these virtual care platforms that have been put out? So we're all engaged in telehealth, and there was some challenges around payment, but I think the Academy's done a fair amount of work on our behalf to ensure that the payments came through. Is that right?
Yes. So you hit it. You're exactly right. The pandemic has accelerated certain trends. I like to tell a story. BC, before COVID, probably a year ago, I was in a shared office. One of the younger guys was doing a telehealth visit, and I said, I'm going to try that. So the next day I tried it and I couldn't figure it out. It didn't work. And I said, okay, I'm never going to do that again. Well, then came COVID, and guess what? I had to figure it out, and I was able to figure it out. And patients love it, especially new patients. And or easy follow-ups. It's great for them. The question is, are we going to get reimbursed for it? So the first step was making sure that it was okay to do, and we weren't going to get in trouble for seeing patients across the state lines. And the second step was to make sure we get reimbursed. So we've been working very diligently with the government, and for Medicare and Medicaid, we're going to get reimbursed for these just like we would for in-face visit. Now the commercials, they except for the ERISA program, sort of do what they want to do. But we're hoping that hoping is the wrong word. We're advocating strongly for an ability to do that because, frankly, the patients really like it. And those of us that do telehealth, as you guys do know, it's probably not the most efficient thing for a doctor, right? Because you got to leave the room, get up on. So it's much easier for us just to stack patients up in person, but it's not easier for the patients, for God's sake. So this is something that patients really like.
Danny, you're nodding along there. Is it part of that you were working on with those committees?
Well, the Academy, and when COVID started, we have a resource center on our website, and it gives all the pearls for managing telehealth within your office or your system, and including how to code it and so forth. And I don't think we've added much to that since the first couple of months. And we have gotten feedback from some people, personally I have, that, started off using it, but as soon as they could get back to seeing patients in the office again, they reverted back to the way what they were comfortable with, what they were used to. And Steph and I had a conversation a little earlier today. And I think using telehealth, I think you're going to have to be a bit more vigilant to avoid errors. There's a recent article published that talked about malpractice issues with telehealth, not related to COVID so much, but timely diagnosis and treatment. An example was a patient that had a swollen leg and was diagnosed over the phone, possible DVT after surgery. They ordered an ultrasound. Patient died the next day before he could have it. So that puts you at a disadvantage. Another example was where, and this was an orthopedic, but where somebody did a telehealth visit, and in their note, they had the patient talked about their cardiac, so they had a regular rate and rhythm. Well, when the patient died of MI, rightly so, they said, well, how did you determine there was a regular rate and rhythm on a telehealth visit? So I think if you're going to use telehealth, you have to step up your game and make sure you're doing everything properly, not just checking boxes on a physical exam that you're actually not doing except visually. And then there are those examinations that occur only by telephone for a lot of people. So I think as we step into this telehealth, again, we were forced into the pool. And to use Tad's analogy, we dipped our toes into it until COVID hit. But now we're forced into the pool, and we want to make the best of this so it doesn't give us a black eye or turn us against the technology going forward.
Yeah, Danny, the idea of what's missing in the telehealth is really sort of ironic. As much as it's a step forward, you ought to be able to measure the patient's heart rate and rhythm and record it. That's part of the digital footprint. Right. The other irony is that you do a telehealth visit, and then you turn that off and go over and type a note in your computer about the visit you just did, and you've got that whole collected digital information about the interaction with the patient, yet we still have to write a note. It's really illustrative of kind of where we are and what we need to do to really make it useful for the provider as well as a great experience for the patient.
Actually, Ted, I'm going to come back and give you all the technology that does all that already, right?
Excellent. That's we're dying to have that. That's what we need.
We have it at
Yeah.
UCSF in my room, not in your room yet.
Yeah.
There's this
Well,
machine that listens to the conversation, puts it right into the note. I don't have to do anything.
Yeah, and it's the microcosm of the whole audience, you know. So if we have it in one room or one place, how can we make it available broadly? Because we can do it, as you say, it's out there, it exists, and it could help if we really got it to be employed broadly.
So talking about crazy stuff like a box is in the room, listens to the conversation, creates a note, populates it, and while it does that, reminds you the 3 things you forgot to ask while coding your note for you, which is all available. We just have to make it broadly accepted and integrated. And behind that, all the guys, you guys are absolutely right. The interoperability piece has to be solved. That's a government level thing. Interstate commerce level stuff has to happen. But if you had a magic wand and the technology piece wasn't an issue, what problems do you think our members, the fellows of the American Academy of Surgery, would like technology companies to tackle next? So we heard about pre-authorization. We talked about making it easier to take notes. What else comes to mind do you think our members would love to see happen? That's a technology-driven solution.
So, you know, basically what I feel is that, you know, technology and this digitalization has helped us with our work-life balance as well, right? But right now, it's creating a little bit more work. Now, Stefano, early adopters like you have figured it out, right? But there's a lag between when early adopters like you can figure it out when the rest of us can figure it out, right? So we really have to work on getting it up to speed so that those of us who are a little digitally naive can integrate this seamlessly in our practice. But again, you know, I think that the interoperability is quite important. And I have a list of, you know, case that, you know, 2 years ago is a well-known case. A guy came in for a knee replacement. He's 45-year-old. He was a vet and had an uneventful knee replacement, went home the same day on Percocet and died 2 days later. Well, you know, in New York State, in order to prescribe a narcotic, you got to check their narcotic use thing, and it looks in New York State. Well, it's not hooked up to the VA narcotic use thing. And the guy had been on, he was on narcotics at the VA, and he was a methadone guy at the VA. Now, you know, look at successful working guy, but he had methadone, and that's not something that people like to talk about. So we didn't know he was on methadone. It was documented. He'd asked several times what medications he was on. He didn't say he was on methadone. So he died from probably too many narcotics, you know, and because he had Percocet and methadone. So this is a case where, and people say, well, there's privacy issues. Yes, we understand there's privacy issues. But this is a case where a patient was harmed because of lack of communication between these. And I really do think it's quite important to do that. And as you said, and the other piece I'll put in, and Danny can magnify this, is they've enhanced the communication between patients and physicians through your medical record, right? But so patients can ping us all the time through we use Epic, but still it's not easy to say when you're going to be working, when you're not going to be working. So if you're not on call on a weekend and you get a note through Epic, my leg is swollen. Well, many of us, you know, feel the need to respond to that because we care about our patients. So that sort of work-life balance has to be ironed out as well, because we have to let people know, okay, where someone's not on call, none available, who is available. And, you know, again, through AI, we could easily make it so that things are tiered as well, things that are true emergencies and not. And there's no doubt, I have every confidence that in the next few years, these things will be worked out and it'll be better for everyone, frankly.
So solving the excessive data output from all this technology and finding a way for us to manage it and corral it, if you will, that'd be a fair summary.
Yeah, there's a lot of noise out there. Too much information, a lot of noise. Sometimes the important things can get caught up in the noise.
And I just tag in there on interoperability. I think this is an industry problem that most software companies, big software companies like Epic, you know, they're proprietary, and they don't have an incentive yet to want to talk to a Cerner or a Meditech or some other system that's out there, all scripts, name them. the point is that the technology industry should be solving this problem. They have the means to do it. And for us to wait on a legislative solution to solve it, we're just kicking the can even further down the road. So I think that's an important thing for us to consider. Something else I was going to say, but I have to come back to it in a minute and let you ask us another question.
Actually, I'm going to go to Tad. Tad, you're here in the Bay Area. You're exposed to a lot of technology, probably more than many. So you have a sense of what can happen. What technology? If you had this magic wand, what problems you'd like to see industry and technology companies focus on for us?
Yeah, I touched on it a moment ago, and I think it's the burden of documentation, and it is sort of intimately related to interoperability or connectivity that Danny and Joe are talking about. So there's this wealth of tools that can collect all sorts of things. You can put a sensor on a patient. You can get their EKG on the phone. You can do a digital visit. But how does that information all get put together and in a form that's usable and visible to the next provider that's looking in the patient's file or making a decision about doing surgery or determining follow-up? We need to figure out how these tools, these great tools that collect very important information, connect with one another and are then useful at the point of care. That's to me the biggest challenge. And ultimately, the goal of this is to decrease the burden of documentation for the provider and increase the satisfaction of the patient in terms of the care that they're getting, because they have the confidence that the information that's out there about them is actually being used and scrutinized and making the decisions that are made about them more specific to their situation. I think that could be very reassuring. It's a great opportunity.
So we talked about interoperability. We talked about the electronic record and data. We talked about work-life balance and the impact it has, and the impact that all this technology has had on our ability to actually keep up with it. There's just such a huge, and there's a fair number of companies, if you will, putting out devices that actually provide us more data. So it's almost frightening. It's like, wait a minute, what are we going to do with this stuff as it comes along? The question sort of came up, and just add a little bit on this one as I'm listening. And also, if each of you has led a large percentage of our orthopedic surgeons in this country, especially in the way they think, is what do you think is going to be the best way for us to introduce these technologies to our fellows in the academy, orthopedic surgeons around the country, and also all those that work with us, the nurse practitioners, PAs, physical therapists? How are we going to help them bridge the gap between the present and the future?
Yeah, so I'll take a stab at that. I think look, we work with very intelligent people, and I think motivation is the key, right? So when these things, it's apparent that all the stuff that we've been talking about is here to stay and it benefits the patients, then I think there'll be a rapid evolution. People will use it. I mean, does anyone remember being told we're not going to wear beepers anymore? We're going to just use our cell phones? No, that was an evolution. We didn't wake up and say, I know, ask the residents if they ever heard of a beeper, they think you're crazy, right? But beepers went away. Now it's cell phones, and pretty soon cell phones will go away. It'll be something else that we can connect with patients for. So again, I do believe that it'll be a rapid evolution once everyone understands that this is the direction we're going to go to. So as leaders, we have to show the benefit that this stuff has for our patients and our profession, and that's not going to be very difficult to do. I think anyone that's been dove head in onto a EMR realize initially, sure, there's a learning curve, but anyone that's used it will never go back, right? It's I talk about interoperability, but I don't have to worry about chasing down x-rays. I don't have to worry about seeing what the cardiologist said at NYU because it's right there. I can talk to patients, new patients, and talk about, well, things that happened to them years ago with some of my partners. So it's spectacular what it gives us. So to me, it's going to be an evolution once the need is shown to be there and once the solutions are there as well.
I see this, everybody that's an orthopedic surgeon sees something from ViewMedi 2, 3, 4 times a day. And frequently it has to do with some kind of technology that's being applied to a surgical procedure. At the Academy, we have our Learning Center. And our Learning Center is basically living, we have excellent facility, but we're still doing cadaver dissections and cadaver type of work in our education process. And our board is going to have a workshop this year on virtual reality, mixed reality, and every other kind of reality is going to be there before we have the workshop. We've just been handcuffed by not being able to meet in person, but we'd at least like to explore the possibility this might be useful in our Learning Center, and perhaps make the Learning Center useful to more of our fellows across the country without having to travel to Chicago, for instance, for a meeting. The other place that we can certainly take advantage of looking at all these new technologies is at the annual meeting. Again, it was canceled last year, so we lost an opportunity. And we've backed it up to late in August this year because we're still under travel restrictions and still a fair amount of COVID out there. But that's the best place for orthopedic surgeons to come and sample all of these technologies. It's all laid out there for you, and you can put your hands on them. And it's actually, to me, a more relaxing place to do it than having some rep come to my office or watch some video online. I think it's better just to have the experience in person. So annual meeting, that's a great place for people to start.
It's a great point. And I want to go back to Joe's example of the beeper going away and the cell phone. And to me, it's a great illustration of alignment. One, the use of the cell phone was aligned with things that we were already doing, and it wasn't a layering on. So many times the technology that we're looking at now is a layering on of something else to do. And we frankly don't have time for that. We need new technology that decreases the burden, that takes away a layer, that doesn't add a layer. And when you hit something like that, like the cell phone, or maybe telehealth is kind of moving in that direction, then it can be a real win. It can't be a layering on, or it's just not going to fly.
Workflow integration, I couldn't agree more, Ted. The minute you start adding variations to workflow integration, the adoption of technology goes way, way less percentage-wise. But if it's in the workflow and it's easy to do and the information is available to you and it's the right information that actually helps you and there's no noise, as Dr. Bosco said, as Joe said, absolutely correct. And I'm really excited to hear that the board is going to be experimenting with virtual reality and seeing that and moving that ball forward, because it's a huge opportunity for us. Absolutely. Whether it's COVID travel or just simply being busy, a resident or fellow will be able to take advantage of resources that Academy can make available, as well as some of the industry partners that will work with us to create those tools and make education broader, freer, more accessible to everyone, so that we can deploy these ideas and these thoughts and test them. And I think another thing it was just one word that you put in your note, in your speech, that may not be put, but you mentioned the concept of measuring the results of these technologies. It is being applied somewhat indiscriminately. We don't even have methodologies right now. We're trying to sort them out. How do you put out an AI, a machine learning algorithm, neural network, goes out there, collects information, throws out answers. It may be a very biased set of answers, as we've seen in other data science projects, which we call things like banking, where if you live in a certain zip code, you're never going to get a loan, no matter what your credit score is, because the AI, the machine learning algorithm, is the algorithm is biased. And so how do you test the efficacy of such an algorithm in the healthcare setting is something that has to be addressed. So I couldn't agree more that yes, embracing this technology while at the same time bringing it to us, the healthy skepticism that we as surgeons and doctors and clinicians in general always bring to anything new that we surface, to ensure that the safety of our patients comes first, right?
Right. Well, kudos to the Academy for leading the charge with the registry efforts that they have underway. I think the reality is a lot of the digital systems that we have been designed for billing purposes, as their original, billing and documentation, not so much assessment of outcome. And so agreed that's another one in the magic wand question. Can we transform these platforms into things that not only document and provide information for billing, but also help us with outcome?
Yeah, I think.
Exactly.
Sorry, Joe.
No, I was just agreeing.
We're in agreement. It's great. So I'm going to take a step back, take a seat with you guys, and turn this over to Shauna to run the Q&A. We've had some questions come in online as we've been talking from the assembled audience, and at the same time, she is uniquely well positioned as a technologist par excellence, very connected to the world of digital health, and really deep understanding of what not only is available today, but what's coming in the future. She may be able to help answer some of our questions and drive our thinking closer to what's possible. So Shauna, over to you.
Hi there.
Hey.
Good to see you guys. Yeah, I was going to say good to see you guys. I have been multitasking, which women and nurses are very good at doing, and following along with the chat to see what's going on, and lots of interesting questions. So let me just start out with a lightning round real quick, and I'm going to start with you, Tad. Favorite technology that you think can solve a pain point for orthopedic surgery?
My favorite technology at this point is the patient communication platform that sort of knows about the patient's upcoming surgery or surgery that they just had and prompts them and collects information and makes them really feel well taken care of. I really like that.
Are you, so I've seen a couple of these where it looks like what I think a lot of us are familiar with when we go on a flight and we get that itinerary that says, here's the time to check in. When you check in, here's what you need to bring. Here's when
Yes.
you're, go to the gate. Yeah, so those are super fun to see how those are coming on board. All right, Joe, favorite technology that you think can help us fix a pain point in orthopedic surgery?
Sure. Voice recognition. For those of us that never learned how to type, and I was enrolled in an adult typing class my senior year in high school, which my mom thought would be a good idea. And I went to one class and skipped the rest and did bad things with my buddies. So I think about that all the time when I can't type. But right now, I with voice recognition, and I remember when Dragon first came on, I'd have to speak more slowly. It was difficult. Now I can speak with my hyper New York cadence, and it gets everything down. It's really wonderful. And with some of the other algorithms, you can, no one has to type anything anymore. So I think voice recognition is.
Don't you love how it has that feature, like it almost is a mind reader? It knows what you should be saying or thinking.
Yes, it does. It really edits half the stuff I say. I wish I had those all the time.
So just an aside, how's your handwriting?
Illegible.
Okay. Yeah, I'm thinking that voice recognition, we're all going to be really happy. It'll solve a lot of pain points. All right, Danny, favorite technology that you think is going to solve a pain point in orthopedic surgery?
I don't really have any others other than what Tad and Joe have said, because there's not proven technology out there. Probably the best thing we've got going for us right now is our smartphone, because it allows us to communicate securely. Almost every hospital has some kind of secure way to communicate so we can share information. So as crazy as it sounds, my trips to the emergency room dropped dramatically when I could start sharing x-rays with the emergency room doctor instead of him telling me it was on the palm or surface of the foot. Well, of course, then I knew I had to go in because he didn't know what he was talking about. But now when I can see the x-rays, it's made a big difference. So even though that's a little bit older, the secure messaging within that platform has been very useful. And I still think that's most useful to almost every orthopedic surgeon out there.
Agreed. And I think that oftentimes what I find in a lot of the conversations that I'm in industry wide, there is this infatuation, I would call it, with what's the newest and the next. And oftentimes some of our oldest, trusted, lowest tech solutions really are the ones that save us a lot of heartache and a lot of friction. All right, Stefano, your favorite?
All right, it's machine learning.
Yeah.
So
Okay.
I'm a data guy. I've always been a bit of a data geek. I love the idea of being able to finally collect all this information and not deal with 1,000 or 10,000, but 100,000 patients,
Right.
eventually 1,000,000 patients, and really start to see the potential of the data to tell us exactly how to treat people and to personalize that information so that I'm not giving a knee replacement to everybody the same way it would have been done in the 200 male men whose cadavers were examined to design a knee, and all of whom were North European descent and of a certain shape. Let's get past that. Let's get to the point where we can use these algorithms to create the kind of care we would give as individuals that know everything about that patient. So
Yeah. I was going to say that opportunity, we have talked so much around precision medicine, personalized medicine, these types of tools combined with the data and the rapid computing power really help to deliver that promise. So I wanted to pick up on a comment, Joe, that you made about digitally native. And what is, I find really interesting, challenging, and also something that's really helpful is at this moment in time, we have 5 generations in our workforce. And they come with a variety of range of digital skills and enthusiasm for embracing digital technologies. So as between you and Danny, you're looking at the members and assessing their interests, their needs, and it's across 5 generations. How are you approaching being a solution for so many different needs? And also, I just want to point out to our audience, Joe, you're up in New York, you work in a highly urban area. Danny, you're in Georgia in the South, in a much more rural, relatively speaking. And Tad, you're out on the West Coast. So we have geographic variations here. We have the types of settings that are different. So we have different infrastructures. So when you think about your membership, and they have different needs, they have different interests, different abilities. What are your thoughts around how the Academy can use digital tools and technology to, I think, bring everybody to a similar playing field and deliver better care for wherever they are, help them to move along to the next level of their practice? And Joe, I'm going to start with you.
Sure. So it's sort of like a one-room schoolhouse, right? You have all kind of grades in this one area. The idea is, though, to bring everyone up to some standard. And people, as you said, people have different learning styles. People come into with different attitudes. They have different aptitudes, and so it's a daunting task. But we have a great council on education, and they're used to working with digital learners. They're used to working with folks that like textbooks. And it's a gradual evolution.
Yeah.
Again, I remember when I used to run the course for board preparation, and when the board exams came up and you had to take them on a computer, I remember first 15 minutes were, well, I've never taken an exam on a computer. What happens if I delete it? You can't. It's impossible to delete. What happens if I can't? What happens if the screen's no good? I mean, people were so afraid of this. But once they started getting used to it, now it's de rigueur. No one ever takes an exam in a book anymore. We don't have to worry about those questions.
Right.
So again, different learning styles. Our academy is very adept to that, but we do have certain standards that we feel that everyone should be doing.
And so, Danny, it's your turn next to be the leader of this academy. You represent a different part of the country, a different stage of career, and you probably have a lot of insights and wisdom that you've accumulated over these years. Have you got some thoughts around how to be, bring everybody in under one tent when you've got such a different range and appetite for the digital technologies?
Well, I'd say since the three of us on the call, well, actually four of us were all analog natives at one time. We've managed to make the transition. Right now, of the over 900,000 physicians in the country,
Mm-hmm.
that's a lot. One third are over 60. One third. But I would guarantee you that almost every one of them, with just very few exceptions, are comfortable with their hospital's computer platform. And the majority are comfortable with their computer platform in their offices. If for a true digital native, somebody that's in their 20s or 30s, that's all they've ever known, well, they've got a leg up on things that not necessarily are needed right now in our care, such as social media and those types of things. But I don't think they're much further along down the road than most practicing orthopedics surgeons, mainly because of the technology where we are right now. In the future,
Right.
they'll have a leg up. One thing I would tell you, the Academy is doing a couple things. One is we've got a huge initiative on resident curriculum, which will roll out, we think, we're hopeful, in the summer. And that will hopefully align our resident training programs throughout the country and enhance education across the country for our future orthopedic surgeons. And currently we have a number of initiatives that are digital. We have a fantastic dashboard that was just released this year on biologics. If you want to know any kind of biologic, where it stands in the FDA process, it's an app on your phone. And that's very useful, and anybody can do that. You can be, like I said, an analog native or an 80% digital native or 20%, and you can still take advantage of that information opportunity. So I think the Academy is working as hard as we can. These things cost money. The registry, to roll out a registry for, say, fracture and trauma, that's $1 million or $2 million every time you do it. But the infrastructure's there. So we're just copying what's already been started with the joint registry. And that's picking up pace. I think Joe would tell you, we're adding about one a year now. And it's moving forward rather smoothly.
Thank you for that. Those are very promising, and I'm sure that as people are listening, they're seeing themselves in your story. And I think that that's what a lot of people are looking for: is meet me where I am and take me to the next stage. Tad, you had I love the way you phrased this, that you talked about the burden of care and how so many people in our care teams are really feeling that right now. And a lot of that is coming from the extra work sitting in front of a computer that is not, the highest paid clerical staff is not what somebody wants to be. And thinking about all the different pain points, the friction. Have you got some thoughts, maybe from your own practice, but maybe looking out across the industry? Where have we seen technology? And again, I'm framing this from the standpoint of we're focusing on our members here. What are some of the technologies and the problems that are causing the stress and the burden, that are, quite frankly, taking the joy and the teamwork out of delivering our really good quality care? So did that question come through clearly? I know I said a lot of words.
Well, no, I think I know where you're going. And
Okay.
one point that occurred to me is that that is right in the wheelhouse there, is that the best technology is intuitive. It's simple. It doesn't matter what generation you're in. You walk in the room, you start talking, it records, it understands your voice and creates a note. You take a CT scan and the 3D printing now puts something in your hands that shows you what is the pathology, instead of trying to intuit in 3 dimensions what the planar scan shows you. So Stefano alluded to the volume of information, the burden of information. That's a huge stressor for providers of care, assimilating that and then documenting. So can we use technology to simplify that? And I think the answer is yes, and there are some good examples.
And I think, Joe, one of the things, as far as you're in contact with members all over the country, for the last year, I have been in conversation with people who are providing direct care, and they're under enormous amount of strain. And I think that they're feeling it emotionally, physically, spiritually, financially. Have you got some thoughts around technologies that will just better serve our members so that they can deliver the care that they want to deliver, that they know is possible?
Sure. So when we talk about member communication with patients,
Mhm.
if that communication is made easier, and it can be done even asynchronously, which would mean you could take a break for 12 hours or 24 hours to get recharged. Because as you said, as people said, this is not about the caregivers being lazy. In order to do the best job we can, we need the time to recharge our batteries.
You
So
might
you could
actually need
work
to get some
24 hours.
time to eat.
Right. Well, that's not a problem with me. Maybe exercise would be a problem. So,
Okay,
but,
meditation maybe?
meditation, yes, meditation.
Yeah.
So the bottom line is though is that we need to be able to handle this information and handle what's expected to us in perhaps an asynchronous manner, which means we can put things off for 10, 12 hours, 24 hours and recharge our batteries and get back to doing things we want to be able to do so that we can provide better care for our patients, frankly.
I'm glad to hear you say that, because we need to take care of our team members so that we can take better care of our citizens and patients and communities. And I just want to personally say thank you for the role of leadership that you've had during this past incredibly challenging year. Like I said, I'm in contact with providers all across the globe, actually, and I haven't heard any of them that haven't been quite challenged by everything that we've been asked to respond to. So thank you for being a voice for them. And I'm sure that as you hand things over to Danny, that he's been resting up and doing all sorts of meditation. So he is absolutely ready to take over this mantle from you. And I'm hoping that you get like a long week of sleep.
Don't worry about me. It's and Danny and Buddy Savoy, our second vice president, and all 250 people that work at the academy and our volunteers. They're the ones that deserve the credit. I stand here before you, but there's been a lot of people that have put a lot of work in to making sure that throughout this year of unexpected challenges, that we've been able to move things forward, stick to our strategic plan, and provide great care for patients. So. Trust me, it's not me. Danny's been working hard, and Tad will be the first one to tell you that when you lead an organization, you have great people behind you. It's a pleasure, and it really makes your job a lot easier. And it's humbling, frankly. Every day I'm humbled by what people are doing to help us out.
So we've got several comments over in the chat box. One I'm going to throw over to you, Steph, which is curious about what interesting technologies that you're seeing on the horizon that are things that we should be looking at that hold promise. And then also, and I'll let you answer that, but the other one is, there's a question about from Steve Waskow, hope I've got that name right, who wants to know, and I think this is a great idea, about the Academy putting on a course demonstrating best practices for a telemedicine visit. And actually, I was just going to say, when we had the COVID response series, we actually had some of our physicians from UCSF who were walking through very nuts and bolts types of a criteria as well as a practice and some of the setup. So it sounds like we're going to, as we evolve and we are including more of this in our practice, there are some great needs from the standpoint of just the how-to, what are people learning that are really good practices. So if there are things that the Academy has like that, we've got people who are wondering where they are and where they can go find them. So yeah, Stefano, if you want to take over from there on that.
Actually, the one about best practices, it fits right into the kinds of thing we'd like to produce on behalf of our audience and potentially get produced in partnership with the Academy and make available as our
DOCSF 365 platform.
Right. So the word I'm looking for is when you get credits.
Continuing education, CEUs.
So that actually you can make CME accreditation to learn these technologies and these tools should be part of the way we get accredited. It is this is foundational to the work we do. It's beyond, it's, one step beyond sutures. Understanding drugs is understanding how to apply them and implement them. So quick call to action on that one, and see if we can find a way to create CME courses for this for our members. Three ones I just wrote down real quick. I could probably go on for a week about this, but I got super excited about synthetic data sets recently. So to bring you up to date, it's the idea that synthetic data, the technology is now available that you can take a data set of, say, 1,000 patients and create a data set that functions identical to that data set, but is not tied to that data set. So any one person, virtual person in that data set cannot be linked to any of the other data sets. But if you run a statistical analysis on that virtual data, you get the same answers if you were running on the original data. Why does that matter? Because it gets away from the whole data sharing challenges around HIPAA and compliance. So, and you can also amplify those data sets. So out of 1,000, you can create 10,000, 100,000, whatever you need for the purpose of machine learning. And you can go into that data set and adjust for biases. So if there aren't enough of a specific population within that, you can amplify that data set differentially. It also allows you to transform. Anyway, the point is synthetic data is fascinating as what it can do in terms of its potential application.
Actually, I want to add on to that.
Yes.
During the pandemic, I got to interview the team at Mount Sinai, and it's their innovation and data science team. And what they've been doing is taking a look at their data, and in real time, they had they actually had offers from Google, from Tesla, from some of the major finance teams, where they said, we can bring our AI and ML teams over. What do you need us to help us to figure out? And they were coming up with predictions on who is going to need to have a ventilator, who is going to be most ready to be transferred out of an ICU, who is most likely to be discharged. So it really helped them to streamline their surgical planning, who is going to need to go on dialysis, their discharge planning. So we are seeing data and innovation teams come together in really interesting ways. And this was clearly demonstrated by the pandemic, and there was an urgent need, but they have gotten really excited, and they've had renal teams come to them, orthopedic surgery teams come to them and say, what problems can data help you solve? So we're seeing more and more of that. And
More and more of that.
yeah, I think that's a really exciting opportunity.
It's not as sexy as diagnostics, that kind of thing.
Speak for yourself. I think it's sexy.
But I think, the beauty of it is that it is structural. So as we're all running up against a problem of resources, where AI is being shown over and over again to be successful, you put it into a hospital and you look at resource reallocation, and you can squeeze so much more, by the way, with that extra effort, with that extra resource, out of the same resource allocation. So there are a number of companies, without getting into details, and hospitals that put this stuff in. They may have paid $100K for it. They'll get $20 million out of increased revenue from it, not because they charge differently, but because they're able to do 15% more work with the same number of ORs, the same number of physicians, same number of staff. Reallocation of resources is a problem that AI and machine learning does really, really well. And if there's one thing that healthcare is, it's not the most efficient place for us to allocate. So I think maybe—
Yeah, I would say, I think Danny's smiling. Yeah, I think Danny's smiling when you say that, because he was referring to the stuff costs a lot of money. So where are we going to find it? All right, there you go. There's your source. I think, all right, guys, I just want to tell you, first of all, welcome to 2021. And when I say that we are glad to have you here, I mean that with the greatest of seriousness and affection. We are really glad that you are here. And I say that from the standpoint of being very mindful that this country, this world, has lost a lot of people. And so as excited as we are, I know that we are also very mindful that there are people that need our attention, our affection, our thoughts, our prayers, and our support, and they need us to solve these problems. And we cannot do it alone. So we're very grateful for your partnership. We are grateful for being, embracing technologies that can help us do more, do it better, do it more safely. And for God's sakes, bring the joy back into all of the things that we do, because at the end of the day, that's why we do this. We are here to alleviate the suffering of people. We are here to heal communities, heal families, give people the ability to be more mobile and do the things that they enjoy and find that bring them the happiness in life. And we're very grateful as part of the DOCSF team to have your partnership, to have your leadership, to have your scholarship, and to get this puppy launched. So with that, I will say thank you guys so much, and we're going to continue on, and we will see you in the new year.